What is the anatomy of cornea? Layers of cornea. First, we have corneal epithelium, followed by Bowman's membrane, followed by corneal stroma, which occupies 90% of cornea. And then fourth layer, we have Descemet's membrane, which is very resistant. Descemet membrane is nothing but the basement membrane of corneal endothelium, which is the fifth layer of cornea. The first layer, the epithelium, gives protection to the cornea. If there is any erosions in corneal epithelium, it will get re-epithelialized without any formation of scar. If the injury involves Bowman's membrane, it leads to superficial scar formation, thereby leading to corneal opacity and associated visual disturbance. Then we have third layer, corneal stroma, where the collagen fibers have been arranged in specific patterns, which gives the transparency to the cornea. The fourth layer, we have Descemet's membrane, followed by endothelium. The endothelium has the pumps, sodium pumps, and other channels which are responsible for maintaining transparency of cornea by inhibiting or reducing the influx of aqueous humor into the stroma. This is about the layers of cornea. Let's proceed on to the most important topic, the first topic, the bacterial keratitis. What is bacterial keratitis? The term itself tells there is keratitis, that is corneal inflammation due to the invasion by bacteria. Before that, let's define what is corneal ulcer. We know ulcer is break in continuity of skin or mucous membrane. The corneal ulcer is nothing but break in continuity of corneal epithelium with associated necrosis of destruction and necrosis of surrounding corneal tissue. The corneal ulcer can be formed due to bacteria, due to fungus, or due to virus. This is the etiological classification of corneal ulcer. First, now we are seeing bacterial corneal ulcer. First, let's see etiopathophysiciology of bacterial corneal ulcer. What are the predisposing factors for bacterial corneal ulcer? Normally, the intact corneal epithelium will not be invaded by organisms. So the intact corneal epithelium is a protection against development of corneal ulcer. But we have three organisms which can invade the intact corneal epithelium, as does 3 marks question many times. Those are Neisseria gonorrhoeae, Neisseria meningitidis, and Corynebacterium diphtheriae. So, we are continuing with predisposing factors for developing bacterial keratitis or bacterial corneal ulcer. That is trauma to the corneal epithelium, breaching the corneal epithelium and letting the organisms invade. The trauma to the corneal epithelium may be secondary to trichiasis, the misdirected cilia causing damage to corneal epithelium. Can be secondary to entropion leading on to trichiasis. And then we have foreign body, or we can have external injury causing the break in the continuity of corneal epithelium, thereby predisposing to development of bacterial corneal ulcer. We have underlying corneal diseases like herpetic keratitis, corneal erosions, bullous keratopathy, and keratomalacia. Corneal diseases. What happens in case of herpetic keratitis? In herpetic keratitis, there is infection, recurrent infection of cornea. The latent virus in the trigeminal ganglion will reach the nerve endings and cause repeated infections and breach in the corneal epithelium, which predispose to bacterial corneal ulcer. The corneal erosions we already know are the risk factor for corneal ulcer, developing bacterial keratitis. And bullous keratopathy is also one of the corneal disease leading on to development of bacterial keratitis. There may be contiguous spread of the disease from surrounding structures like chronic dacrocystitis and other diseases can lead on to development of bacterial corneal ulcer. And also we know always immunosuppression, reduced immunity will lead to development of corneal ulcer. That is seen in diabetic mellitus patients, systemic immunosuppressive therapy, and then in case of malnutrition. So we saw the predisposing factors for bacterial corneal ulcer, that is trauma, secondary to injury, entropyon trichiasis, the corneal diseases like viral HSV keratitis, corneal erosions, and bullous keratopathy, leading on to the break in the epithelium, which predisposed to development of bacterial keratitis, and contiguous spread of infection from chronic dacrocystitis, reduced immunity in diabetes mellitus patients, in systemic immunotherapy, immunosuppressive therapy patients like transplant patients, and in case of malnutrition, which reduces immunity of the patient, the patient is predisposed to develop bacterial keratitis. Now, what is the pathophysiology of bacterial keratitis? It's the pathophysiology of bacterial keratitis. We have different stages of bacterial keratitis. The stages of bacterial keratitis are stage of infiltration, stage of infiltration and progression, stage of regression, and stage of cicatrization. So the stage of infiltration and stage of progression has been divided into two separate stages in AK Kurana. It is mentioned as stage of infiltration and stage of active ulceration instead of these terms. These are just tiny change in the terminology. Those are essentially the same. What happens in case of stage of infiltration? In stage of infiltration, there is the bacterial invasion. Bacteria has invaded, and there is immune cells secondary to invasion of bacteria will come to the cornea so that it can fight back the infection. During the stage of infiltration, both the bacteria and our immune cells will come to the cornea. After that, both of them will cause destruction of corneal epithelium. The immune cells trying to destroy bacteria, along with destroying bacteria, will destroy the surrounding corneal epithelium, corneal structure. So in the stage of progression, we have destruction of corneal epithelium and surrounding structure leading on to ulceration. In stage of regression, we have the immune cells will be successfully eliminating the bacteria, and then the inflammatory response slowly slows down. And then we know all the injuries are followed by fibrosis. Similarly, after the stage of regression, we have stage of cicatrization where there is fibrosis of cornea, corneal layers. If it has gone beyond Bowman's membrane, which is usually the case, it leads on to development of corneal scar. Corneal scar will cause corneal opacity and distortion in image formation. That is distortion in vision. This is about the pathophysiology of corneal ulcer. Let's see what are the clinical manifestations seen in case of bacterial corneal ulcer. What are the clinical manifestations seen? We know we divide clinical manifestation into two, that is symptoms and signs. What are the symptoms that we see in case of bacterial corneal ulcer? we see acute onset of pain, redness, and lacrimation. Why acute onset of pain, redness, and lacrimation? We know the inflammatory cells are attacking the cornea. There is immune response, which leads on to production of some proteins. The substances released by immune cells will cause increased sensitivity of the brain ending receptors. And also there is surrounding destruction of corneal epithelium, leading on to development of acute pain and redness. Associated with that, there is increased receptivity of corneal sensory nerve endings of V1 branch, which leads on to lacrimation. And also lacrimation is due to the secondary response to wash away the invaded bacteria. There is secondary response, that is lacrimation. The patient will have decreased visual acuity due to corneal edema associated with this inflammatory process. There can be white spot on cornea due to destruction of the structure, that is necrotic base and all. Now, what are the signs that we see in case of corneal ulcer, bacterial corneal ulcer? There is, coming to signs in eyelids, we see blepharospasm and lid edema, which is obvious. There is ciliary congestion of conjunctiva due to increased vasodilation of the local blood vessels, which are secondary to the release of inflammatory mediators like histamine and other inflammatory mediators by immune cells, leads on to ciliary congestion and circumciliary congestion in corneal ulcer. So there is ciliary congestion in conjunctiva. The ulcer in the cornea, we see the ulcer. The description of ulcer is very important. The ulcer is grayish white. It has circumscribed infiltration with edema of surrounding tissue. The grayish white lesion, the necrotic ulcer, followed by circumscribed infiltration and edema of the surrounding tissue. The edema is responsible for decreased visual acuity. So later, the extent of ulcer can be delineated by doing fluorescence staining, which gives the brilliant green color to the ulcer. Later, the ulcer becomes gradually smooth, and in regressive cicatrization phase, they will form the scar, the corneal opacity. The hypopyon may be present in some cases in the anterior chamber. You can see hypopyon in some patients. And also intraocular pressure may be raised in the presence of hypopyon due to blockage of trabecular meshwork by the inflammatory cells and the pus in the anterior chamber. But if the ulcer perforates, there is decrease in IOP, which we will see shortly. Okay, these are all the signs and symptoms seen in bacterial corneal ulcer. What are the signs and symptoms of bacterial corneal ulcer? The symptoms are acute onset of pain, redness, lacrimation, and decreased visual acuity. We saw the reasons for each of these things. And then the signs are eyelid edema, blepharospasm, conjunctival congestion. The ulcer, we have the corneal grayish white ulcer with surrounding edema, and then which may lead on to go on to develop a scar in the later stage. In the anterior chamber, we can see hypopyon, and secondary to hypopyon, the IOP may be increased. These are all the signs and symptoms seen in bacterial corneal ulcer. Later, this healed ulcer will progress to develop corneal opacity, which is of three types, that is nummular, macular, and leukomatous. I request you to read through this corneal opacity. It has been asked as 3-mark question once, many times. Now, what are the complications of corneal ulcer? What are the complications? Complication has been separately asked as 5-mark question, so please pay attention. The ectatic cicatrix, thinned scarred cornea bulges under the influence of normal IOP. What is ectatic cicatrix? Ectatic cicatrix. So here we had cornea. The cornea had developed corneal ulcer. After the healing of this ulcer, there is fibrosis. This fibrotic tissue is not so strong. Since it's not so strong, due to IOP, intraocular pressure, it bulges out. This is called as ectatic cicatrix. Then we have desmetocele complication. What is desmetocele? If the ulcer goes inside till the descemet's membrane, this descemet membrane bulges out like this. I told that it is very resistant, so it will not get injured or necrosed easily. Under the influence of IOP, it bulges out. It is called as desmetocele. Then we have one of the most important complications, that is perforation and its effects. The perforated corneal ulcer has been separately asked as 5-mark question. So please listen to it. It is caused by sudden exertion, that is sneezing or coughing, which causes acute rise in IOP. The weak floor of ulcer is unable to support the pressure, so it gives away, leading on to perforation of this ulcer. So you can see this is the desmetocele. The desmetocele secondary to increased IOP, increased pressure, or the corneal ulcer secondary to increased pressure can't sustain the increased pressure, which is secondary to coughing or sneezing, so it will perforate out, leads on to perforated corneal ulcer. They vary in location and size of perforation. We have anterior. Now this is about perforation, how it develops. Now, what is the advantage of perforation? Perforation is not so useful, but what is the advantage of it? After the ulcer perforates, the pain relieves. The patient will feel better due to relief of pain, which is due to lowering of IOP following perforation. There is better nutrition and more antigen antibodies reaching the ulcer due to diffusion of fluid through the perforated corneal ulcer. So it leads to rapid healing of ulcer. This is about the advantages of having a perforation. Don't think like that having perforation is good, because we have many disadvantages which we will discuss now. The complications of perforation are anterior synechia, where if the perforation is very small, the iris becomes gummed down to the opening and the adhesion organizes. In case of anterior synechia, we have the cornea. We had small ulcer where the iris bulges out and seals this. Following that, there will be organization of tissue fibrosis, leading on to anterior synechia. We have iris prolapse. The iris prolapses when this ulcer is very large. It is necrosed, whole cornea is gone. The iris will prolapse into the cornea and cover the defective area. This is called as iris prolapse. Following that, there will be organization of fibrotic tissue on top of this prolapsed iris. Organization of fibrotic tissue on top of this prolapsed iris, leading on to adherent leukoma. Then we have one of the last complication, we have thesis bulbi. In case of large perforation, there is extrusion of the contents of the eyeball, leading to shrinkage of the globe with lowering of IOP, which is called as the thesis bulbi. In thesis bulbi, there is oozing out of the content of the eyeball, leading on to shrinkage of the eyeball, which is called as thesis bulbi. Then we have subluxation, dislocation of lens. Secondary to perforation, the lens may sublocate because IOP has been reduced and the contents are moving out. There can be anterior subluxation of lens, dislocation of lens. We can also have anterior capsular cataract secondary to this. Then we also have corneal fistula developing secondary to corneal perforation. All these are complications of corneal ulcer, bacterial corneal ulcer, that is ectatic cicatrix, desmetocele, and perforation. Now, how do we manage this condition? How to manage this condition? How to manage? We have investigations and treatment under management. What are the investigations that we do? The routine blood examination like CBC, differential leukocyte count, where we see increased leukocyte level, leukocytosis. Then we can do corneal ulcer scraping, and then we can send it for culture and sensitivity. We can do culture and sensitivity, gram staining. Then we can identify the causative organism by sensitivity testing. We can identify the antibiotics which are effective against the bacteria, and we can treat accordingly. Then we have treatment of bacterial corneal ulcer. The identification of organisms is important. So it is done by smear preparation and culture and sensitivity testing of corneal scraping, which I told previously. Meanwhile, the aggressive treatment of antibiotics should be started before we get the report. So what are the topical antibiotics that we are using? We have topical fortified drops. Topical fortified drops. The fortified cefazolin, fortified tobramycin. Fortified tobramycin is 2 ml of parenteral tobramycin plus 5 ml of bottle of commercially available tobramycin eye drop. That is fortified tobramycin. We can give fortified tobramycin and fortified cefazolin eye drops for the patient initially. We can also give subconjunctival injections of the antibiotics. In case of severe disease, the subconjunctival given usually is gentamicin, 20 to 40 mg. The systemic antibiotics are not usually given, but in case of marginal bacterial ulcer and perforating corneal ulcer, and if the sclera is involved in the perforating corneal ulcer, and if there is involvement of the sclera, we'll give systemic antibiotics for the patient. What are the other drops that we give to the patients? We can give atropine sulfate 1% to improve the circulation and reduce the pain. Atropine 1% solution to improve circulation and reduce the pain. Why the atropine will improve circulation? Atropine will cause meiosis and improves the circulation. No, atropine is anticholinergic drug, meaning it causes mydriasis, relieves the ciliary spasm, and increases the circulation, thereby relieving the pain. Then we can do heart fumigation, which improves the circulation and relieves pain. We can give analgesics to the patient, antipyretics to the patient because the patient may have associated fever. We can give tablets, acetazolamide and timolol to control IOP. The IOP is increased in case of hypopyon in anterior chamber. So to prevent the glaucoma, acute glaucoma, we can give tablets, acetazolamide and timolol. If the ulcer doesn't respond to this treatment, we'll go on to debride and cauterize the ulcer. This is all about bacterial corneal ulcer. And also, please note, in case of desmodocele, we'll give rest to the patient. We'll ask the patient to take rest, and we'll apply pressure bandage, because the increase in pressure will lead on to perforation, which is not accepted. So we'll give rest to the patient. We ask the patient to take rest and give pressure bandage, followed by therapeutic keratoplast. This is all about the bacterial corneal ulcer. We discussed etiopathophysiology, the predisposing factors, the pathophysiology, stage of infiltration, stage of progression, stage of regression, and stage of cicatrization. Signs and symptoms: acute pain, redness, lacrimation, decreased visual acuity. The signs: we have eyelid blepharospasm and eyelid edema, circumcorneal congestion, and then we have ulcer, grayish white, followed by the scar, and then we can have hypopyon, which may increase the IOP of the patient. The complications we saw: ectatic cicatrix, desmodocele, perforation. And perforation, we have many other complications due to perforation, that is anterior synecdoche, iris prolapse, and adherent glaucoma. Followed by that, we saw investigation, blood investigation, and culture and sensitivity of corneal scraping. The treatment, we have topical fortified drops, that is fortified cefazolin and fortified tobramycin. Subconjunctival injection of gentamicin, and systemic antibiotics in case of perforated corneal ulcer and scleral involvement. Also, we can give 1% atropine, analgesics, and tablet acetazolamide. If the patient doesn't respond to this treatment, we'll debride or cauterize the ulcer. This is all about bacterial corneal ulcer. The hypopyon corneal ulcer is a type of bacterial ulcer caused by Streptococcus pneumoniae or pneumococcus. The corneal ulcer in case of hypopyon corneal ulcer is typically serpiginous in fashion, so it's also called as ulcus serpens. What is the etiopathophysiology of hypopyon corneal ulcer? We have, it is commonly occurs in old debilitated patients and in case of alcoholics. Causative organisms, we saw it is pneumococcus. What is the source of infection? Most commonly, there is contiguous spread of infection from surrounding structure, that is lacrimal apparatus, chronic dacrocystitis. The infection from the pneumococcus bacteria from dacrocystitis spreads to the cornea, leading on to hypopyon corneal ulcer. Now, what are the symptoms that we see due to this cause? Clinical manifestations. That we have symptoms and signs. What are the symptoms that we see? Same as bacterial corneal ulcer, but there is remarkably little pain due to during the initial stage, and the treatment is unduly delayed. We saw that symptoms will be acute pain, redness, and lacrimation, photophobia, all these things. What are the signs that we see? Same as bacterial corneal ulcer, because it's also a bacterial corneal ulcer. What are the signs that we see in case of hypopyon corneal ulcer? The sign is very, very important. Please note. There is grayish white, disc-shaped ulcer near the center of cornea. Disc-shaped ulcer near the center of cornea. Grayish white, disc-shaped ulcer near the center of cornea. The ulcer is more at the edges than at the center, and particularly well marked in one specific direction. The cloudy gray area surrounds the ulcer area, and again more marked in the same direction. On one side, the ulcer spreads, while on the other side, it may undergo spontaneous cicatrization, and the edges may be covered by fresh epithelium. The whole cornea may become hazy. What the textbook is telling to try is, we have the ulcer. It starts as a grayish white ulcer, which will spread in both peripheral direction. At one side it will be spreading, and other side it will be healing, leading on to particular ulcer serpens. Due to this, there will be inflammatory response, and the whole cornea will be hazy to look. Due to this corneal ulcer, which is very, very severe, it causes iridocyclitis, secondary inflammation of uveal tissue, and the exudation of inflammatory cells from the iris, the uvea, causing hypopyon. And then there will be, in conjunctiva, we can see conjunctival and ciliary conjunction, which we all know. Lids, we can see edematous lids and spasm. Now, what is the course of this disease? Hypopyon corneal ulcer. What's the course of the disease? Hypopyon corneal ulcer. The hypopyon corneal ulcer has the great tendency to perforate. It's one of the sequelae. The hypopyon may increase in size. Hypopyon may increase in size, leading to secondary blockage of trabecular meshwork, leading on to secondary glaucoma. Ultimately, there can be panophthalmitis, very deadly condition secondary to hypopyon corneal ulcer. So we saw clinical manifestations as symptoms and signs. What is the treatment of hypopyon corneal ulcer? Hypopyon corneal ulcer treatment. Treatment is almost same as treatment of corneal ulcer, but it has special points. The overhanging edges of ulcer should be excised. The overhanging edges, which may be edematous, should be excised. Excision of overhanging edges. Paracentesis, that is removal of hypopyon if the hypopyon is massive. And if the patient has secondary glaucoma, we should be treating the patient with the tablet acetazolamide or timolol. Or if there is any evidence of chronic dacrocystitis, we saw due to chronic dacrocystitis, the patient may develop hypopyon corneal ulcer. We should do dacrocystectomy. Let's proceed on to discuss fungal corneal ulcer. Viral keratitis due to HSV virus, herpes simplex virus, herpes zoster ophthalmicus. The other important topics like keratoplasty, keratoconus, and interstitial keratitis, I will not be covering. I urge you to please go through the topic once. This fungal keratitis or fungal corneal ulcer. The name itself suggests that it is a corneal ulcer caused due to fungal infection. Mycotic keratitis, fungal keratitis. What is the etiopathyphysiology of this condition? The causative agents are, it can be filamentous fungi, it can be yeast. The filamentous fungi are Aspergillus and Fusarium. The yeast can be Candida albicans and other yeast. So these Candida infections are frequently seen in immunocompromised hosts, which you already know. We have studied it in our microbiology. What are the predisposing features which leads on to fungal keratitis? The predisposing factors are same as bacterial keratitis, that is trauma or secondary corneal conditions like bullous keratopathy, etc., corneal erosions and all, and also injury with vegetative matter is associated with corneal ulcer. Injury with vegetative matter and with animal tail will lead on to the development of fungal corneal ulcer. The mode of infection, we saw mode of infection, mycotic keratitis is typically produced by ocular trauma, mainly by agricultural and vegetable matters. And also other predisposing factors are indiscriminate use of topical steroids, which lead on to reduced immunity locally and also immunosuppressed patients. What are the clinical manifestations seen in case of fungal keratitis due to these infection? The clinical manifestations, we know we have symptoms and signs. What are the symptoms that we see in case of fungal keratitis? In fungal keratitis, the symptoms are less prominent compared to that of bacterial keratitis. We'll have eye pain, acute onset of eye pain, lacrimation, photophobia and all, but it is less compared to bacterial keratitis. What are the signs that we see in fungal keratitis? Ulcer will be dry looking, yellowish white lesion with indistinct margin. The filamentous fungal keratitis has delicate margins which projects into adjacent stroma. The filamentous has delicate margin which presents into adjacent stroma. It may be surrounded by grayish halo and multiple satellite lesions. Very, very important. It may be surrounded by grayish halo and satellite lesions. The candida keratitis will not be yellowish white, rather it will be typically collar button abscess like feature with feathery, without any feathery edge. We'll see here. The cotton button abscess like ulcer without any feathery ends is seen in yeast infection, that is candida infections. The yellowish white dry looking ulcer with feathery margin is seen in filamentous fungus causing corneal ulcer. The underlying epithelium may be involved and it may be elevated. Some degree of iridocyclitis and massive dense hypopyon are common. What is the type of hypopyon that we see in case of fungal keratitis? Unlike bacterial corneal ulcer, which is sterile, the fungal corneal ulcer, the hypopyon will have the fungi filaments. The fungi will invade through the descent membrane into the anterior chamber, and also it is non-sterile and it is not mobile, non-mobile. Vascularization usually will not occur. It occurs usually in case of bacterial corneal ulcer. What are the investigations that we do in case of patients with fungal corneal ulcer? In the patients with fungal corneal ulcer, we'll do the scraping of the ulcer, and then we'll do 10% KOH mount, where we can see the filamentous fungi or the candida eaves. We can do fungal culture using Sabrod's dextrose agar, and also since we will not know clinically whether it is fungal or corneal ulcer, if we have doubt, we can also do culture and sensitivity testing for bacteria, gram staining and all. What is the treatment of fungal corneal ulcer? The scraping and debridement of ulcers. Very important, scraping and debridement of ulcer. Followed by atropine eye ointment 3 times a day. We saw why atropine eye ointment is given 3 times a day, because atropine will cause mydriasis. And then due to that, there will be increased circulation, which leads on to reduced pain suffered by the patient. What are the topical antifungal agents which are prescribed to the patients with fungal corneal ulcer? We have natamycin 5% eye drops, which is given 1 hourly. It is effective against most common fungal corneal ulcer caused by Fusarium and Aspergillus species. In case of, if the patient have candida ulcer, the fungal corneal ulcer due to candida, we have amphotericin B, topical amphotericin B, 0.15 to 0.25% can be used as treatment. Alternatively, we can use voriconazole eye drop 1 to 2 hours, or natamycin eye ointment we can use 5 times a day. So what are the systemic therapy that we give in case of fungal corneal ulcer? If the ulcer is too deep, marginal, or if it is perforated, we give systemic fungal. If the ulcer is too deep, marginal, or perforated, we give systemic antifungal agents like tablet fluconazole. May be tried for 2 to 3 weeks. The cauterization of the ulcer can be done in case of non-responsive cases, same as bacterial corneal ulcer. The therapeutic full thickness keratoplasty is much better solution for resistant fungal corneal ulcer. This is about the fungal corneal ulcer. We saw the etiopathophysiciology. The filamentous fungi like Aspergillus and Fusarium causing the fungal corneal ulcer. The yeast like Candida albicans causing it, which is most common in immunocompromised patients. The predisposing factors are immunosuppressed patients, and then injudicious use of topical steroids. The injury with vegetative and animal tail, vegetative matters and animal tail is associated with corneal ulcer. What are the symptoms that we see in case of fungal corneal ulcer? The symptoms are same as bacterial corneal ulcer, that is acute onset of pain, and then we have lacrimation, blepharospasm and others, but it's less marked compared to bacterial corneal ulcer. The other signs we have, the ulcer, try looking yellowish white ulcer, but the ulcer is cotton button abscess like in case of candidal fungal ulcer. We have hypopoion, which is non-sterile and non-mobile. We also have grayish halo due to formation of immune ring, and also we have satellite lesions in case of fungal corneal ulcer. We investigate this by using 10% KOH, and we can do saprolite textures agar culture of fungus. We can also do culture and sensitivity for bacteria. The treatment, we have scraping and debridement of ulcer followed by atropine 3 times a day. Antifungal agents like natamycin 5% and amphotericin B. If the ulcer is too deep or if the ulcer is perforated or marginal, we can use systemic antifungals like fluconazole for 2 to 3 weeks. If the ulcer is resistant, we can try cauterization, and at the end, still the ulcer is resistant, we can do therapeutic full thickness keratoplasty. We have finished with bacterial corneal ulcer and fungal corneal ulcer. Let's proceed on to discuss about the viral keratitis. We have HSV associated keratitis and herpes zoster ophthalmicus. First, we'll see HSV associated keratitis, that is herpes simplex virus associated keratitis. Herpes simplex virus, we all know it's a DNA virus. We have 2 types, HSV1 and 2. The HSV1 occurs above waist and the HSV2 occurs below waist. The HSV1 is usually transmitted by kissing. The HSV2 is usually transmitted venerally. We are seeing that the HSV1 is caused due to kissing, and the virus during primary HSV infection, which occurs usually at 6 months of age and 5 years of age. It leads on to acute follicular conjunctivitis, which has already been discussed, and it leads on to mild disease, fine epithelial keratitis. The treatment is simple. Acyclovir, give acyclovir 5 times a day for 3 weeks. This is very mild. After this primary infection, the virus will go and remains latent in the trigeminal ganglia. Upon any stress like common cold, fever, menstruation, etc., the latent virus in the trigeminal ganglia will travel back to nerve endings and cause the recurrent herpes simplex virus associated keratitis. Due to this reactivation of virus, we have epithelial lesions, stromal lesions, and endothelitis. The epithelial lesions ulcers are punctate ulcer, dendritic ulcer, and geographic ulcer. The stromal lesions are immune stromal keratitis, necrotizing stromal keratitis, and the endothelitis causing disciform keratitis. The epithelial lesions, coming to epithelial lesions, have punctate ulcer. The punctate ulcer or the small epithelial erosions due to HSV infection. This is very mild disease. Followed by dendritic ulcer, where the ulcer coalesces to form tree-like branching ulcer with peripheral knobs. It is called as dendritic ulcer. The dendritic ulcer present to us with acute onset of pain, redness, and lacrimation, which is the clinical manifestation in all the corneal ulcer. The signs are circumciliary congestion due to inflammatory response secondary to this ulcer. The lesions we have, first, before the development of this ulcer, will have whitish plaque. Following that, that whitish plaque will erode to form the tree-like branching ulcer called as dendritic ulcer. And also, due to this HSV1 infection, will have reduced corneal sensations in dendritic ulcer. How to treat these patients? Give 3% acyclovir 5 times a day for 10 to 14 days. Next, if these dendritic ulcer coalesce and enlarge, they form amoeboid or geographic like ulcer called as geographic ulcer. We have stromal lesions like immune stromal keratitis or interstitial keratitis and necrotizing stromal keratitis. In immune stromal keratitis, the antibodies which are produced against the virus will cause stromal destruction, leading on to symptoms like photophobia and mild discomfort in patient with reduced corneal sensations. Since this immune stromal keratitis or interstitial keratitis is caused by immune attack, we can give steroid drops for 4 to 5 times a day, which reduces the inflammatory response. Along with that, we will give acyclovir 3% 2 times a day. In contrast to immune stromal keratitis, we have necrotizing stromal keratitis, where the virus invades the stroma and causes the destruction of stromal tissue. It leads on to cheesy necrotic material. The stroma will convert it into cheesy necrotic material, which may be associated with perforation, scarring, and vascularization later. The necrotizing stromal keratitis is treated by steroids and acyclovir, oral or topical agents. What is endothelitis disciform keratitis? It is a deep disc-like edema, where here it's a delayed hypersensitivity response of the body to the viral antigens, leading on to endothelitis, that is inflammation of fifth layer of cornea. Corneal endothelium get involved. Due to endothelitis, we know corneal endothelium is responsible for maintaining, in preventing corneal edema. So when it is damaged, we develop corneal edema. Due to that, the patient will have edema. Clinical manifestation will have edema and visual acuity disturbance. We have mild and severe disciform keratitis. We have different manifestations. In mild disciform keratitis, we have fine keratic precipitate due to associated anterior uveitis, mild anterior uveitis. And we'll have severe edema of the cornea, leading on to visual impairment, reduced visual acuity. If it is severe disciform keratitis, we'll have deep vascularization along with marked anterior uveitis. Mild form, we don't see necrosis of tissue and vascularization, whereas in severe form, we see deep vascularization and marked anterior uveitis. How to treat this disciform keratitis? We give atropine, acyclovir ointment, and corticosteroid 4 to 5 times a day. Next, let's proceed on for discussion of herpes zoster ophthalmicus. What is herpes zoster ophthalmicus? Herpes zoster ophthalmicus is the condition caused by the varicella zoster infection affecting the eye. Varicella zoster virus will cause vesicular lesions in the skin and all. After that, similar to HSV associated infection, it will go and remain latent in the trigeminal nerve. Upon stresses like fever, common cold, and other stresses, the herpes zoster ophthalmicus will get reactivated travel to the periphery, V1 distribution of herpes zoster, V1 distribution of trigeminal nerve, and cause vesicular eruption at the dermatomal distribution, and characteristically vesicles at the tip of nose called as Hutchinson sign. We all know this. So, what is the pathophysiology of this herpes zoster ophthalmicus? After initial exposure, the virus remain dormant inside the trigeminal ganglion, dormancy. Under stress, it migrates and causes distribution along V1 distribution of trigeminal nerve. The Hutchinson signs we all know. When the tip of nose is involved, the eye will also be involved, since both are supplied by nasociliary nerve. What are the symptoms we see in herpes zoster ophthalmicus? The vesicular eruptions around the eye, forehead, and scalp due to dermatomal distribution of V1. Severe pain along the distribution of ophthalmic division of fifth nerve due to reactivation of virus and the associated destruction of the tissue. The photophobia and lacrimation. What are the signs that we see? We have 3 stages in herpes zoster ophthalmicus. Those are acute lesions, chronic lesions, and recurrent lesions. The acute lesions are the lesions which develop within 3 weeks. The chronic lesions are the lesions which may persist for up to 10 years. The recurrent ones are the lesions which reappear after 10 years. Let's see each of them briefly. In ocular lesions, the lids will be edematous. There will be vesicular eruptions in the eyelids. This is very obvious. Edematous lid due to inflammation, and vesicular eruptions due to varicella zoster virus in the eyelid, followed by conjunctival signs like acute mucopurulent conjunctivitis. It can cause acute mucopurulent conjunctivitis. In the sclera, we may have scleritis or episcleritis. The cornea, we can see punctate epithelial keratitis. What is punctate epithelial keratitis? I already described it while describing HSV associated viral keratitis. Punctate epithelial keratitis, or microdendrites, which are small, fine, multiple dendritic satellite lesions. Characteristically in cornea, we can see nummular keratitis, which is specific for this herpes zoster ophthalmicus, where it is multiple granular lesions surrounded by halo stromal haze. You can see here multiple granular lesions surrounded by stromal haze halo. This is called as nummular keratitis. And also we have disciform. We can see disciform keratitis in case of acute lesions of herpes zoster ophthalmicus also. The sensations will be decreased or absent in case of herpes zoster ophthalmicus. What are the iris signs? That is acute iridocyclitis with or without ephema and patches of iris atrophy. The IOP may be raised due to acute iridocyclitis, causing KPs and other manifestations where the inflammatory cells can go and block the trabecular mission. In the retina, we can have acute retinal necrosis. The neuro-ophthalmological manifestation, we can have optic neuritis in case of acute manifestation of herpes zoster ophthalmicus. And also there can be associated cranial nerve palsy. What are the chronic lesions seen in case of herpes zoster ophthalmicus? We can see ptosis secondary to scarring in the eyelid, which is seen in acute lesions. Scarring in the eyelid seen in acute lesions will lead on to ptosis. Due to the involvement of eyelid, we can have misdirection of cilia, trichiasis, and entropion, inward direction of eyelid. Lid notching may also occur. These are all lid complications. We can have mucus secreting conjunctivitis, mild inflammation in the conjunctiva continues, so we can have mucus secreting conjunctivitis. We can have nummular and disciform keratitis continuing for many years. 7% of patients present as post-therapeutic neuralgia, which is worse at night, aggravated by post-herpetic neuralgia or post-therapeutic neuralgia. Post-herpetic neuralgia, where the patient will have night pain along the distribution of V1 nerve, which is worse at night and aggravated by touch and heat. And also, at last, we have recurrent ocular lesions, recurs after 10 years, like episcleritis, scleritis, episcleritis, scleritis, iritis, nummular keratitis, and secondary glaucoma. This is all about the signs that we see in herpes zoster ophthalmicus, the acute lesions, the chronic ones, and the recurrent lesions. How do we treat this condition? How to treat herpes zoster ophthalmicus? We give oral acyclovir, 800 mg, 5 times a day for 7 days, which reduces pain, accelerates healing, and curtails the vesiculation. Pain can be relieved by giving analgesics. We give antibiotic and corticosteroid preparation for skin lesions because we have, when the vesicular lesions can get secondary infected with bacteria. So to prevent that, we can give antibiotic and corticosteroid preparation. And also we can give topical steroids in the presence of corneal involvement, anti-uveitis or scleritis. If the patient has disciform keratitis, nummular keratitis, etc., we can prescribe topical steroids. Topical antibiotics we already saw to prevent secondary. This one. We can give systemic steroids. These patients, what are the indications? Systemic steroids are given in case of optic neuritis and cranial nerve palsy, which we see in acute, which we can see in acute phase of herpes zoster ophthalmicus. And also in order to reduce the occurrence of post-herpetic neuralgia, we can give systemic steroids to the patients. Artificial tears and bandaged contact lens we can give for persistent epithelial defect. And at last, if the patient has dense scarring of cornea, we should do penetrating keratoplasty. So to summarize, herpes zoster ophthalmicus, we saw idiopathogenesis, primary infection, dormancy in trigeminal ganglia, and then again upon stress, the reactivation of virus. The symptoms: vesicular eruption, severe pain, and photophobia lacrimation. The signs we divide into acute lesions, chronic, and recurrent. Acute one presents with lid signs, conjunctival, scleral, corneal, and iris, and neuro-ophthalmological involvement may be there, leading on to optic neuritis and cranial nerve palsy. In chronic one, we have up to 10 years. The patient may have ptosis, the mucus secreting conjunctivitis, nummular keratitis, and then nummular keratitis, disciform keratitis, etc. In the recurrent lesions, the patient may have episcleritis, scleritis, nummular keratitis, and secondary glaucoma. The treatment we saw, we give oral acyclovir 800 mg 5 times a day for 7 days. Strong analgesics, topical antibiotics, and steroid preparations we can give. Systemic steroids given in case of optic neuritis and cranial nerve palsy, and to reduce the occurrence of post-herpetic neuralgia. We can do penetrating keratoplasty if the patient have dense scar due to herpes zoster ophthalmicus. By this, we are completing these 3 topics. So I am not completing keratoplasty. I am not doing keratoplasty, keratoconus, interstitial keratitis, and corneal opacity. I request you to go through these questions and the 3 marks question. By this, we are done with cornea.